we are doing this in the EUS of.
Can they hear?
आवाज साफ नहीं आ रही है, थोड़ा सा नजदीक कर लो और मुंह
आवाज आ रही है सर अभी?
कुछ बेहतर है, बोलो।
जी हाँ, we have a patient, 38 years old male patient with no previous comorbids. Basically, he visited private hospital with a chief complaint of epigastric pain, fullness, decreased appetite. Patient workup was done in which the endoscopy was done for the dyspepsia symptoms, but we had an incidental finding of esophageal submucosal lesion at 25 centimeter. So we are doing our EUS to biopsy that lesion and look that lesion, and also if needed EUS FNB. So incidental finding of submucosal esophageal lesion.
So can you hear me?
Yes, yes.
Okay, so just before Dr. Junaid starts, I just wanted to make a few points about intubation. I understand Dr. Khalid has explained one way and Dr. Mustafa has explained another. I tilt more towards Dr. Mustafa's way, so doing it like a normal endoscopy. But just like a normal endoscopy, the key thing before intubation is the patient's position. So ideally, the head should not be tilted to one side or the other. There's a tendency when we say to the patient, just look down, niche dekhen, so they tend to move down towards the floor. But actually, their head should be square on with regards to their shoulder. So it shouldn't be tilted either way, otherwise intubation can be difficult. The other thing is that see if we can flex the patient's neck, just like a normal OGD, but be a bit more, just insist that the patient's position is right before intubation. So as Khalid Bhai mentioned, if you see the tip of the scope where the bending area is long as compared to a normal OGD scope. So to put it in, obviously you need to move in, and then what I tend to do is that I move the tip down and then I try to move my hand slightly upwards so that essentially going above the tongue into it. One of my consultants used to say that once you are at that position, if you raise the hand, then the scope tip can turn and sometimes it can make it easy to go in. So there are various techniques, but essentially the key thing is do not push hard. If you are getting stuck, pull the scope out and then try a different technique. Okay, so off to Junaid.
Thank you. Air water suction check है sir, with balloon load किया हुआ है.
Okay. Okay. I would look at the patient's face, there's no need to look up, when you're doing it. Excellent. Okay. It's slipping in? Yeah. Okay. Excellent. Yeah. Yeah. So I think this patient had submucosal, he had an esophageal lesion at roughly 25 centimeters. So we'll just see if we can visually see it. It may make things easier. That's what the CT report suggested, yeah. So yeah, that's a good view. So keep on, see if we can visually. Yeah. I think there it is, isn't it? Yeah. So yeah, just come a bit further back, just so that you can get a good visual. Just rotate the scope slightly so that you can, make sure that it's the right place visually. We're just looking at the endoscopic images to start off with. Yeah. So it's probably that, yeah, just come back, further back, yeah. It's very difficult to say whether it's just a deflated esophagus or a mass because I can't, yes, the mucosa looks a bit abnormal there, doesn't it? Yeah, it looks a bit rough. So if you can, so are you at 25 centimeters? Just come back further back, come further back, so then you can always go forward, isn't it? So just to make sure that you're not missing anything. But I'm sure you are in the right area. Yeah, that's the one. Yeah, okay.
I'm 25 right now. I'm at 25.
Okay, just come a bit further back, and then you can always go back in. Yeah, just keep on looking around. Yeah, keep on looking around. Yeah, excellent. So that, yeah.
शायद कह रहे हैं कि यूएस की इमेज ट्रांसमिट होने के लिए
Okay, yeah, that's fine. We can just,
बताइए बिग बी को
sorry?
यूएस का मैं बिग बी दे दूँगा
Actually, we're trying to visualize it endoscopically before.
20 now.
Yes, okay, now that's fine. So now you're sure that you're not missing anything. Now you can go forward, you know. So we were just emphasizing the need of visualizing things as well through normal endoscopy, because things can otherwise get missed sometimes. So there seems to be some mucosal irregularity here, and we're roughly at 26, 27 centimeters, isn't it? Yeah,
This is the one, right?
yeah. It's not a huge mass-like thing, but yeah, there's an ulcer-like thing, isn't it? So
looks like not
yeah. So the fact that you can see the lesion in front of you suggests that the probe is probably 1 or 2 centimeters beyond it. So you can then now try to rotate the scope. Yeah, excellent. Rotate the scope so that you're
just
above it.
like-
I think we
so
can see it now endoscopically, yes. Okay. So now we'll move to the endoscopic image. Yeah, excellent. And then just try to see if we can, you know, differentiate. So certainly there seems to be something there. Where is it coming from? It's a bit challenging just to see it from one image. So ideally I tend to go to the edge of it to see if you can, you know, see if it's in continuation with the muscularis layer or the submucosal layer. Seems to be a lymph node there as well, isn't
Yeah.
it? That,
Yeah.
So that area,
that's
is
the
there a
bulk
marker
of it.
here? That,
Yes.
you know, yeah.
Yes.
Yeah. So there's a lymph node that we can see here, and then, you know, there's a lymph node. This seems to be like a lymph nodes, and that's where the mucosal
yeah.
sort of mass seems to be. You can see these lines coming up because you're close to the trachea here, and there's air there, yeah? So try to rotate it clockwise, and therefore you can then, you know, so interrogate the lesion a bit more. So can we enlarge the lesion a bit? So the images, I will enlarge the image.
That is
No, so just increase the image, yeah, magnify it, yeah, make it bigger, yeah, excellent, yeah, that's great.
So I think this is the normal like lining of the esophagus.
Um,
You can appreciate the
Yes, so this probably is the serosal lining
Yeah.
or the adventitia, you know, so it probably is coming from the muscularis or
Muscular, yeah.
certainly is involving the muscularis
Yeah.
mucosa. Any comments from the group? Can you guys hear us?
Yes, we can hear you, Shahzad.
Okay.
We are looking at the images, very interesting, with a good interest. So, you think that this lesion is rising from the mucosa and is penetrating the muscularis layer?
Well, it certainly is involving that area. Whether it's arising or not is a bit challenging to say. Ideally, we will probably try to go to the edge of it to see if we can identify the normal esophageal, you know, linings, and then see where it's coming from. Okay, so if you just try to push the scope in now, further in, yeah, excellent. So that's where all the thing that we can see here. Keep on pushing it in further. Just see
Shahzad,
if we
can you
can
measure that lesion? How big is that lesion?
Okay, so we're just trying to keep on going for, so if I measuring,
yes, mesh.
So this one, yeah.
yeah, okay.
Pause for now.
Pause there. Okay, so I'm sorry, you're familiar with the Pentax system, this is new to me.
Yes, hमें size 12
Yes,
So,
so
it's
it's
roughly
12,
about 1
yeah,
per 2
10
centimeters.
centimeters, yeah. Okay, yes, please. Okay, oops, sorry. Yeah. So if you keep on going in, further in, just let's see where it's up till what point it is, yeah. Okay, keep on going further in, keep on going further in, yeah, keep on going further in. So it seems to be going quite deep, keep on going further in. So it's, the length it seems to be more, yeah. And there's it where it ends sort of. Keep on going in, further in.
So, Shahzad, looking at the lesion, what do you think? What could it be?
But to me, it looks like it's probably malignant. It looks as if it's, you know, a carcinoma.
Yeah.
It doesn't look like a benign submucosal lesion as it was suggested on the CT scan. To me, it looks as if it may be esophageal malignancy. So if you pull the scope back, yeah. So if you see here, this is a good
I think
image.
if you look at this lesion over here, it is heterogeneous, it is few of the areas are more hypoechoic,
Yeah.
and then there's another hypoechoic nodule
Point.
down in the lumen,
Yeah. So if I don't,
and then there's an element of edema as well in the center, maybe some necrosis, but serosa is well preserved.
well, if
and
in this
there's certain
area,
lymph nodes here, yeah.
yeah, if you see, look at this area, the serosa seems to be broken here. If you
Yeah,
keep
right
on,
here,
yeah,
it-
yeah, if you see here, it seems to be as if this lesion is going across the serosa. So if you rotate it,
Yeah.
yeah,
fine.
in this area,
Yeah. So you're way beyond.
you know,
what
it
you-
seems as if it's T4
it
based
might
on
be
this.
penetrating the vessel down there, like if you can like see it's
It's probably close to it, but not.
Butting maybe?
Yeah, yes, probably.
Yeah.
Yeah. Okay, and now pull back slightly. Now, keep on pulling back, yeah, pulling back, pulling back. So my assessment would be that it's certainly, you know, in this particular area, it's involving the muscularis propria, but beyond that, it seemed as if it was T4 and had gone beyond the serosa.
Shazad, you're saying involving the muscularis propria. Are we able to differentiate different layers here? I think
Not really,
Yeah,
but
we are not
based
able
on the
to.
fact that the serosa is, you know, based on that, that's the first hypoechoic, you know, area beyond the serosa. I'm just basing it on that. But you're right, the mucosal layers are not very clear.
Shazad,
here.
for the sake of comparison, will you please demonstrate the layers of the esophagus at a proximal or distal area?
Okay.
the liberty of balloon.
So yeah, so why don't we just rotate the scope to the normal area? So let's see if we can just rotate it in the same area. It's probably not. So I think the images are not coming up very clear here, but so push it down. Further, yeah. No, just yeah. So that's where the mass is. Yeah. So we want to go to an area that is away from the mass. So if you just pull back, you know, or rotate it. Yeah. So that, you know, here you can see this is the muscularis propria layer. Can you see that here,
Yes,
the
we can see
hypoechoic
that,
area?
yes, that's right.
And then this hyperechoic area is the serosal layer. So we can certainly make out these two layers. And beyond that, actually here you can see the submucosal layer as well, just at the tip of it. And then, you know, you can see a few
So
layers.
Junaid,
here.
if you rotate gently towards the lesion so that we may be able to see the transition of normal mucosa to the abnormal mucosa,
Yeah, so-
we may be able to see the kind of change that's visible there.
So here it seems as if it may be coming from the muscularis, you know, propria. If you see, rotate right your scope. So here, if you see, this is the muscle layer. Yeah. Keep on going. Keep on going.
So big wheel
Here.
little away from you and then towards you, so that we may be able to make out whether the mucosa is intact or mucosa is the site of origin.
I believe from here we like the lesion is starting and
So
this is
yeah.
the point here.
Yeah. So keep on rotating on the right, like you were doing. Yeah. Yeah. Keep on going. Yeah. Keep on going. Keep on going. So at this point, if we, you know, see this hypoechoic layer, and now if you rotate back towards the lesion, so it seems as if the muscle is, you know, it seems to be arising from the muscle area. And beyond that, it seems as if the serosa is broken here. Okay, so the plan here was to see the lesion and to take some biopsies of this area. I mean, to be honest, we can take some superficial biopsies as well. However, there are some lymph nodes there as well. So what does the group feel? Should we do endoscopic biopsies or EUS guided biopsies?
I think that's the
Why don't you take the endoscopic biopsy simply because the lesion is appeared there, a visible there.
Yeah,
Can we take the endoscopic biopsy?
Yes, there is an argument to say, look, you already demonstrated that it is at least T3, if not T4, and there are lymphadenopathy there as well. So it's at least N1 disease. And if you can see the lesion, then ideally you should do just endoscopic biopsies just to save the cost.
And it will be cost effective as well.
Dr. Ghyas, what do you think?
I think we can go either way, but just to make it cheaper, I shall like to go with the endoscopic biopsy first, and bite and bite, I shall like to have deeper bites in this case. But yes, we can go for EUS guided biopsy as well, because it's a fairly thick lesion,
Yes.
and we can take a full thickness biopsy from here.
Yeah. Okay, what should we do for the, do we have a normal endoscope?
So
Yes.
Shahzad,
Yes.
Dr. Nawal is saying that previously biopsy has been taken, endoscopic biopsy has been taken, and that is inconclusive. So
Okay, we'll go for
that
the
means that
US.
we have
yeah.
to go for the
EUS guided.
EUS guided biopsy.
Okay, yeah, yeah. Okay, so
US guided.
so which needle would the group use? Any ideas? Any preferences? We'll use a 22.
22G,
Yeah,
FNB, Boston side.
yeah.
I think
Yes.
I shall go with 22 gauge FNB. Let's ask Mustafa and anybody else who wants to comment.
Suction.
Yeah, usually that's the standard starting needle these days, 22 gauge F&B, and doesn't really matter which brand it is. They all perform about the same.
So yeah, so in the era where just the FNA needles was, there was a lot of need for cytology, etc., and the pickup rate was less. But with the FNB needles and use of Mohs, the pickup rate has become very good. So in our hospital as well, we just tend to use FNB needles, and 22 seems to be a good midway. So I've told my nurses that whatever I ask, just give me the 22 FNB. It's usually what I want. Okay.
Yeah.
Yeah. Do you want to? Are the trainees allowed to do the biopsies, or?
Shahzad, I think you're supposed to do the biopsy.
Okay, okay. So I'll just have another look at this place that we are looking at. So it is quite a sizable area, you know, that's involved. It's probably at least 5 to 7 centimeters long. Okay, so this looks like a nice area. I'd like to just apply some Doppler there, you know, before I go in. Yeah. So just putting the needle in, as Dr. Saad said, when you push it in, just make sure it goes in very smoothly, because that means that it has come out of the bridge area. What I tend to do as well, I just open up and push the sheath all the way out until I can either see it endoscopically or in the EUS. So I can see it there now. So I'm much more comfortable that we are out. And then you can pull it back up as much as you want. But just as a first instance, I tend to push it out so that we are not damaging the scope.
Shahzad, a question came up. If you have lymph nodes and a lesion, which one do you go for? What's your preference?
So ideally, if we have opened a needle, then probably both. But if I were to go for both, then I would go for the lymph node first and then the biopsy of the lesion afterwards, just to avoid cross-contamination. But if you were to go for only one area, then obviously the lesion, because you need to get to the main area. And there are some genetic tests now. They tend to do the sequencing tests, in which they actually say that you have to have the biopsy from the main area rather than from the metastases. Okay, so I'll just try to put some Doppler there just to make sure. So as we know the needle always comes from the top left area. So we just need to make sure that there's no blood vessel there in between. Yeah, so we can remove the Doppler now. So we know that we are in the right place. We can see I'm just trying to poke the needle gently to see where my line of fire will be. So we are pretty safe here. At this point, I tend to move the tip slightly up. Obviously, take the stylet slightly out, make the needle a bit sharper. We tend to do it right at the end so that we can protect the scope, because inadvertently you can sometimes fire the needle into the scope. And once it's in place, then just a quick jab should be able to take you in. So at that point, the stylet is taken out. There are various techniques. Some people use the slow pull technique. To be honest, I don't bother that much. I do apply suction. Can we apply some suction? There's a group that, I think Khalid Bhai says probably just take one biopsy first without suction, and then we can take things from there. A few passes. I tend to go right to the end, because usually the middle bit can have necrotic tissue in it. Yeah, you can apply some suction, yeah?
Yes, please.
So just to get a good sample there. Again, some people, just move it to and fro slowly. Other people have a jabbing sort of technique. So whatever tends to work for you. Taken the sample, and we'll see what we've got there. So a few things about taking the sample bit. One was the most important was to make sure that the needle is safe and you're not opening it into the scope. And for that, I tend to, as I said, move the sheath all the way out, and then I pull it back up. I then check whether the needle is out by moving the bridge. I can see it endoscopically and in the EUS. Just make sure that it's in the right place. And after that, I just then sharpen the tip by moving the stylet back. Once we are in, you can use the fanning technique, in which you are trying to take the biopsies from various areas. Just remember that the larger lesion, sometimes the middle bit can be necrotic, and you actually want the biopsies more from the edge of it. So I tend to go right to the edge to take the biopsies and send the sample off. I was just wondering about the group, what they think about suction, the application of suction during the first pass, or would they do it afterwards? Oh.
So I think usually for FNB needles, I'd still do the slow pull technique.
Okay.
It's very variable in our unit. Some people use that. We generally don't use suction. Most people, we may even just go without any suction or slow pull, just do the needle back and forth. But Dr. Ghas, aapka kya?
I think in majority of the scenarios, I also go without using suction. So just the slow pull technique. Since we do on-site cytology as well, so I'm pretty happy with that.
So one of the sort of arguments in favor of not using suction is that, especially in lymph nodes, if you apply suction, you may get a lot of blood sample. So a lot of people just go through. It's not. So if you guys can see it, we have got a sample, but my nurse has told me that he's not entirely happy with it. So we're going to take some more samples. So again, we just position it where we need to be. I'll just make sure that the needle is out. So it seems that I can see it. So I'm going to pull it back up again. Just make sure that we don't damage the scope. So what they did, I think there's been a slight error that they didn't put the stylet in. Ideally, I would like the stylet, but for next use, because if you put the needle in without the stylet, then you risk damaging the scope, because the needle tip is very sharp. But that's okay. Now we are out anyway. Whatever is done now. So again, we'll just put the Doppler in again. We'll just put the Doppler just to make sure that there's no vessel. That's fine. So we can take the Doppler off. So another thing to remember is that the Doppler does distort the image, so just use it when you need to, and then you can take it off just for the beginner. So again, a quick jab in, so we're in. Now this is an important area. If you can't see the needle, that means usually that you're not in the right plane. So rotate the scope gently, and you should be able to see the needle. And you should see the needle tip before you are taking the biopsies, so that you know exactly where you're going. So like in this bit, I'm going very close to the edge, you can see, but I can do that only because I can see the tip of the needle. Okay, so there seems to be some extension of the lesion beyond that area as well. So we're just taking some samples using a bit of fanning here. So I'm tended towards using suction, if that's okay. Yeah, please. Okay, excellent. So we seem to have got that. Yeah, excellent. That's great. Okay, let's see if we can get more samples this time around. Do we have cytology on site? Yes. So, okay. So apparently we do have on-site cytology, so rows, so they're going to see whether we've got adequate samples and
So how many passes would you like to make, like 3 with a good sample?
so that's a good question about the number of passes. Usually you tend to have a feel of whether you've got the sample or not. So if it's a hard adenocarcinoma and pancreas, you tend to just pass it once or twice and you know you've got something in it. If it's a soft lesion like this one or mixed echotexture, then I tend to do a bit more passes. But at the end of the day, it's that you need to get the sample.
Dr. Shahzad, ये cytology वो वहाँ पे लगाएंगे तो that can be showed in the screen as well. If you ask the person,
Okay.
cameraman over there. So
Have you got it? Have you got the cytology yet? I think they're still working on it.
and they can show the biopsy sample as well.
Yeah.
So that
So can we turn the camera towards that, what the pathology guys are doing? Can you turn the camera towards them? Oh, they've got another camera, is it?
Just this one. So would you like to review the celiac area as well in this case or no?
Okay, so that's a good question. Probably not in this because of esophageal, but I'm just trying to see the endoscopic image now. Okay, so I'm not sure whether you can see it or not, but it seems as we've got a very good sample now. So
no,
yeah.
we can't see the.
Okay.
We can't see the other screen actually.
Can you see it now?
It's appearing.
I'm not sure even now if you can see it, but we've got pretty good samples. So another common indication for doing mediastinal endoscopy EUS is for mediastinal lymph nodes. So we tend to, at our hospital, send for MTB PCR as well as biopsies and lymphoma panel. I think cytology is now ready, is it? Okay.
Would you like to take another sample or you're
No.
happy with it?
So I seem we've got a pretty good samples now, so I don't think we should take any more samples from it. So we're just going to remove the scope and see how things go. Yeah. Sorry. So we'll just see the histopathology. Don't send the scope yet. We'll just for 1 second. Okay. That's fine. इसको भिजवा दें. Sample तो आ गया है.
सैयद असर ये बताइए कि एंडोस्कोपिकली आप गैस्ट्रोस्कोप के साथ सैंपल भी लेंगे इसमें जो अगर इसको हटा के
अच्छा सवाल है.
क्योंकि ये है कि मैं अगर आप कहें तो मैं स्कोप चेंज कर दूँ
हाँ मेरे ख्याल से भी हैं. दे दें. मेरे ख्याल में हाँ. दे दें. हाँ. I think. So our nurse has said that why don't we just take a normal sample as well via, you know, a normal OGD. So we're just going to put a normal OGD scope to see how it looks like. मैं समझ नहीं आया.
मैं कह रहा था कि मतलब आपको स्कोप अंदर रखनी चाहिए थी so that you can demonstrate
हाँ.
and
Views are.
picking it up.
Hmm.
That's why I was asking if you like to go to the CA
Mhm.
or the data to look up there.
चलो. 3 days we'll do it again. I guess you're right, but असल में patient का वो है ना. How did you feel intubating?
It's comfortable.
Comfortably, yeah. So it's quite nice. The scopes are the Olympus scope. The Pentax scopes are really challenging to intubate.
It's easier to keep your scope over there. Yeah. So,
Do you want to go in and just do the biopsies? Yeah. So Vasim, how are we doing? Sample enough आ गया? Sample तो आ गया ना? हाँ उसमें आ गया. Can't figure out in this? हाँ तो ठीक है हाँ. क्योंकि वो ग्रुप इज वेटिंग अभी क्या बता दें. Can we see the lesion?
ahead of the lesion, I'll come back.
Yeah, that's where.
जहाँ पे रुके
That's where our needle was went
Yeah.
on the side, yeah. That's where you need to take the biopsy from.
Open.
Can we put that endoscopic image on the? Yeah, endoscopic image रख सकते हैं? Yeah, हाँ रख सकते हैं.
होल्ड
So there's been this long discussion regarding rows versus mows. So for the newcomers, one of the arguments was initially when the EUS was developed that you need to make sure you've got enough sample, and especially with the FNA needles, you can never confirm. So you had to have the cytopathologists in the room to confirm tissue adequacy and to see whether a preliminary diagnosis can be made. However, with the FFB needles, you tend to get a core which can be seen visually. So MOSE has been developed essentially that if you can see the sample, then you probably have got enough. And I think the more newer guidelines are tilting more towards the MOSE rather than rows because of the cost and logistical challenges. I think some of the hospital, as Dr. Ghias's center and Dr. Saad's center has the facility, but certainly in our center we don't have the facility of having rows per se. We do have a histopathologist that sort of closely works with us, who we can call, and then he can look at the sample at a very short notice, but he is not actually in the room. वसीम कुछ आगे कुछ क्या लग रहा है I don't know. हाँ
डिफरेंट साइज डिफरेंट शेप एक दूसरे के ऊपर
आप लोगों के
overlaps किए हैं।
कुछ साइटोलॉजिस्ट तो नहीं है इधर ना सब आप एक्सपर्ट आप हैं अच्छा तो what would you say that is we've got adequate samples, so that's one thing that we said and yes,
White core on the
excellent, and we seem to have got it from the right place, so I think that is enough. Yeah. So I've just had a chat with Wasim, and he's saying that although he can't be sure of what it is, but it certainly doesn't look normal, the cells, and we seem to have taken it from the right place. So I think at this we'll probably conclude the procedure. We've taken some extra samples as well endoscopically, and we'll see how things go. You've got the samples, have you?
Yeah.
Okay, that's fine.
Open करना.
I think that's a good sample, yeah. Thank you. ये आगे पे कमाई. वैसे हाँ आगे पे. स्कोप तो चला गया ना हम रख लेते हैं.
भाई बाहर से होता मुझे बुला आप हमेशा बुलाते हैं वर्कशॉप